Hello, everyone. We're going to get started now. I'm Patricia Manti with USAID's Water Office, and thank you so much for joining us today for this webinar hosted by the USAID Water, Sanitation, and Hygiene Partnerships and Learning for Sustainability Project, also known as WASHPaLS. WASHPaLS has been examining how community-led total sanitation has contributed to the goal of ending open defecation, and the project will be using key findings from a desk study review assessing the knowledge base on CLTS program performance. The findings and identified evidence gaps will inform WASHPaLS' research agenda for subsequent years of the project. Our moderator today is Jessie Shapiro, the Environmental Health Team Lead and Senior WASH Advisor and Sanitation Focal Point in USAID's Global Health Bureau. Our presenter today is Jeff Albert, who is the Deputy Director of WASHPaLS and co-founder of the Aquia Institute. And during the discussion, he'll be joined by Morris Israel, the WASHPaLS Project Director, Caroline Dallaire, who is a Research Program Manager at the Aquia Institute, and Valentina Zuin, who is an academic collaborator with the Aquia Institute. Please note the location of the Q&A box on the lower right side of your screen, and you can submit questions at any time during the presentation, but questions won't be answered until Jeff has stopped speaking. And if you have any technical issues, Clarence on our technical team will do his best to help you out, and he'll monitor the Q&A box for any issues. And you can also contact him directly by selecting USAID Water Team if you look under the People tab, and you can do a private chat with him. I also need to let you know that today's webinar is being recorded, and we'll be sharing this recording later this week on globalwaters.org, which is USAID's new water sector knowledge hub. And you'll be able to find the slides from today's presentation in the handout section on the upper right hand of the screen. And one more little technical issue: on the upper right of your screen in the gray box, you'll see a set of arrows that say full, and that allows you to adjust the size of your screen, and you can make the slide presentation larger. So I'm now going to turn things over to Jessie Shapiro.
Thanks so much, Patricia. Good morning to everyone. Thank you so much for joining us. As Patricia stated, today we're here to talk about CLTS, Community-Led Total Sanitation, and contribution from our global health project in Washington called WASHPaLS. Before I hand over to Jeff to get into the content of the presentation, I'll give you a really quick background. What is WASHPaLS? What is this funny acronym? WASHPaLS stands for WASH Partnerships and Learning for Sustainability. It is exactly what it spells out, and that is it's primarily a learning project that seeks to learn in partnership with key partners, primarily national and subnational governments, NGO partners, academic institutions, private sector organizations. Even within the WASHPaLS consortium, which is led by Tetra Tech, we have members from all those different type of organizations as well. And you'll be hearing directly from our research partner, Aquia, today. This project is led out of the Global Health Bureau in USAID Washington, and it's a 5-year project that just started last year. Now, why is USAID funding this project? What is our interest? Well, our interest is the sector's interest, and that's what most countries signed up to with the SDGs. We're really looking at and concerned with achieving universal access to sustainable sanitation and hygiene in the sector. We know this is a huge challenge. Some countries have already been implementing sanitation programs, seeking to try to achieve this at scale. Some are getting to scale, some are finding some success, some are finding lots of challenges. And so we're really interested in trying to understand how can we really take all those different groups of countries and take them to achieve universal, support them to achieve universal access in these areas. And sort of our high level key framing questions for our interest here was, we wanted to look across approaches that are being widely used in the sanitation sector in particular, and try to understand when and how are these sanitation approaches effective and sustainable, how much do they cost, and how then can we repeat this success of those approaches at scale. Now, what this project hopes to then contribute in the sector is, we want to identify and prioritize some research areas, learning areas where we can learn with partners to try to figure out and answer some of these questions. One such approach that we've chosen to do this on is CLTS, which is widely adopted in the regions in which we work. And like some other areas that we've also prioritized, we started this exercise by doing a global desk review and key stakeholder interviews to really understand what is the state of CLTS implementation across the world. This desk review that we're going to share with you today, which is the focus of this presentation, will hopefully we'll start to identify and highlight some areas where we'd like to do and conduct research with partners over the next 4 years. Some of the other areas that we're also looking at, of course, are market-based sanitation and in clean play spaces for infants and young children. But again, today, this review is particularly going to be focused on community-led total sanitation. So just before handing over to Jeff, we're gonna one quick poll to get you try to understand the state of where everyone is at coming into this webinar. So hopefully a poll just popped up on your screen. If you can please answer that question and submit, we'll get sort of a baseline idea where everyone's coming from today. And if you go over to the right side of your screen, in the box where there's chatting and stuff, if you click on the poll and see the open one, you can actually see how the distribution across the participants today, where everyone is coming from. As the poll completes here, I'll just also plug, I'm about to hand over to Jeff to get into the content of the presentation. If you have any questions as we go, and at the end, of course, we'll also have a question and answer period, you can put them directly into the Q&A box there on the right, or the chat box, and I'll be collecting them as we go. So with that, I'll hand it over to Jeff, who can start the content of the presentation. Take it away, Jeff.
Thank you, Jesse. And thank you everyone who's calling in. Just an administrative note, this talk should run about 30 minutes. And then we've budgeted on the order of about another 45 minutes for Q&A and discussion. So we very much hope that that the presentation will lead into some rich discussion. Now normally one ends a talk with acknowledgments, but I'd like to actually begin this presentation by acknowledging all those who have been involved in the design, the implementation, the promotion, the refinement of CLTS, especially the folks who are doing the really hard work on the ground. And it appears that many folks like that are represented here among the attendees. CLTS really does, we believe that CLTS really does amount to a revolution of sorts. Its spread has been astounding. Here you see a map which shows the countries that in which CLTS has been implemented, a good chunk of which actually includes CLTS as part of their national sanitation policies. And the color there corresponds to the date of introduction. And there are many reasons to believe that CLTS can be a world-changing intervention. just another quick aside, I also want to thank a number of researchers with whom the WASHPaLS team has been informally consulting over these months, some of whom are attending today. And we may be calling on you by name during the discussion because we make reference to some of your work. Development interventions, don't typically achieve this level of scale if they don't possess real potential. And so this webinar and the desk review that we've done that is being presented here aren't intended as a pure critique of CLTS. Any development intervention can be critiqued for any number of reasons. Our purpose here is to ask questions about CLTS's success at achieving very specific sanitation-related goals in order to understand where it fits among the full menu of options for both ending open defecation and moving households and communities up the ladder. So what these overarching questions we're asking are whether CLTS has the potential for real large-scale, national-scale change, what we know about how well CLTS works in different settings and what its constraints may be, and what are the most important gaps in our knowledge and how can we fill them. So just a quick note on our methods. So this is not a systematic review and meta-analysis, but it was an extensive search and survey. The literature collection on which it's based, which has now upwards of 3,000 records, will be made public via the USAID CKM project over the course of the next several months, and we very much hope that you and your networks will be able to make use of it. We winnowed down the articles that supported the review down to about 130 documents, both peer-reviewed and from the gray literature. And I also really want to emphasize here that we tried to supplement what we were reading about with interviews with some key people who basically were able to who we asked to provide some ground truth to complement what we were reading in the papers. And Valentina Zuin of the WASHPaLS team is here on the call, and she conducted those interviews, and we're hoping that we may be referring to some of those interviews in the Q&A, and that perhaps some of the key informants we interviewed may even be joining this session. So what is CLTS? In 2008, Kamal Carr, who's often thought of as the originator of CLTS, and the CLTS Knowledge Hub together published a handbook on CLTS that many of you might be familiar with, which is really the closest thing there is to standards or guidelines on CLTS. And reasonable difference of opinions have come up over the core minimum elements. And you sometimes read that there's bad CLTS or good CLTS practice out there, which either diverges or is consistent with the model. But we've identified some common denominators. One is that it's a collective action process. It's very much focused on the grassroots as opposed to individual households. It's really about the collective. It works via a triggering event centered on disgust at open defecation. And it's very much a departure from earlier programs, often government programs that subsidized toilets at their full cost. In terms of what tends to vary, the use of shaming is something which, although it was fairly central initially to the development of CLTS, is variably emphasized or included. Other elements of the triggering event are often included or excluded based on the local context, as is the intensity of follow-up. The definitions of ODF, as many of you know, can vary widely from place to place. The nature of verification and certification, and then of course what's combined with CLTS in some settings, whether it's enhancing the supply side via interventions like Sandmark, or trying to address affordability and liquidity constraints on the very poor. But we'll discuss this in a bit. But some of this variation makes our analytical purpose a bit challenging because CLTS is not really a single unified intervention in many settings because it's so variable. So we asked, what's the evidence that CLTS can contribute to national scale change? And And so what I'm showing here are a set of plots. On the y-axis, you've got rural open defecation from 0 to 100%. And those are estimates from the joint monitoring program of WHO and UNICEF, from the source data, not the fitted estimates that JMP publishes year to year, but these are from individual surveys, whether it's DHS or national surveys that are conducted in a given year. And where they occurred in the same year, we just averaged those. And on the y-axis, you have the year. And now I want to caution that this is a figure that's intended to generate hypotheses, not to offer any kind of conclusions or inferences. But here you see the years at which CLTS was introduced in different countries. And this is also a bit of an unfair figure. An inflection, if we were to see an obvious effect of CLTS, we might expect a point of inflection after the introduction of CLTS, where you'd start to see a steeper drop off, a change in the slope of that curve, which hopefully is going to be trending down over time. That's probably a bit much to expect, given that it can take a number of years for CLTS to really get embedded into national policy, to be implemented professionally, to work out difficulties and so forth. But there are some intriguing trends here. Ethiopia, Nepal, Bangladesh, there do appear to be places where that are suggestive of some change in that slope. But again, this is just intended to generate hypotheses. One thing I do want to draw attention to is Zambia. Be careful about reading too much into just 2 data points, but you do see a dramatic drop in reported rural open defecation in Zambia recently, and that does co-occur with the implementation of an ICT-driven monitoring system in Zambia that has generated some reportedly really radically impressive results. And we may return to that. We'd be happy to return to what we've uncovered there during the Q&A. Okay, so moving along. This is not unique to CLTS, but there's undeniably a data problem that constrains our ability to assess the success of CLTS. This quote is from a 2015 UNICEF review of CLTS in East Asia and the Pacific. There simply are data availability is a problem, and data quality appear to be a problem. Even the most enthusiastic of CLTS advocates and supporters have remarked that a lot of CLTS data can be inflated, and that poses a problem, because this project is very much a data-driven project, an evidence-driven project, and the evidence good evidence can be hard to come by. Remember, when we're evaluating the success of a program, what are the questions we would want to ask, and what are the parameters we want to track? Village level open defecation, either as a percentage, or whether the village is ODF or still practices OD. I mean, obviously we prefer a percentage, but in many cases that we have a binary statistic. Do we also count toilets? What we're going to be talking about, counting toilets versus measuring open defecation, a little bit later in the presentation. How many? Some programs measure success by just reporting on the number of villages that have declared or been verified ODF. But again, it's uneven. Which parameters are measured tends to vary across countries and even within countries sometimes. When are data collected? Are they collected at baseline prior to triggering, or are they only collected from triggering onward? And then with what follow-up frequency? In many cases, we see that the data collection may stop at the point of ODF declaration, and there is some evidence that communities can backslide. We'll be talking about that in the future, again, later in the presentation. Who collects those data? This is rather important. Are monitoring data collected by people who may have a stake in reporting success or failure, or who may be incentivized to report success? Are they collected by third parties? Are they collected by oversight or regulatory officials? And then where are the data stored and how are they stored? Are they digital? Can they be accessed easily? Are they consolidated? All these challenges all provide something all provide some difficulty in being able to assess how and where CLTS has succeeded or failed. Now, I don't want to dwell on this, but the measurement of open defecation is not trivial. And it's most intrinsically because it's very difficult to prove a negative, to prove that there is no open defecation. If an evaluator spends an hour in a village, are they really able to determine that no one in a particular village is openly defecating, or even what fraction of the village are openly defecating? Coming up with methods to reliably measure it is challenging. And counting toilets is a lot easier. And so one question that we posed is understanding that a CLTS is very explicitly focused on a behavior change around open defecation as opposed to building toilets. And of course, the two are related, but and reinforce one another. But we did want to see, the question we asked is, what do we know about the relationship between open defecation and private toilet ownership in a given location? And this is a figure from the PhD dissertation of Ben Arnold at UC Berkeley back in 2009. And each data point there represents a village. The triangles are control villages, the circles are intervention villages. What I really want you to focus on is that there's a fairly tight distribution there where we may be able to generally infer, at least within an order of magnitude, what open defecation it looks like based on private toilet ownership, which is, again, vastly easier to measure. And what I draw your attention to here is that if we were to follow that distribution down out to 100% toilet ownership, you'd still have on the order of 20 to 25% open defecation, which means it's really important to locally validate this relationship. So these data are from Tamil Nadu in southern India. The slope of that curve and the tightness of the distribution may well look different in a place, in parts of sub-Saharan Africa, for example. The other thing I just want to mention is that we have to be very careful about asking community members about whether they openly defecate after they participated in a CLTS triggering event, because in many cases they may have been shamed into recognizing that open defecation is an unhealthy activity and an undesirable activity, and even if they continue to practice it, they may be highly disinclined to report truthfully after that. So these are challenges that we need to think about. All right, I'm going to stop there, and I think we're gonna do a second poll. Before we get to our top line results, we'd love to get a sense of your a priori sense of how well CLTS works. So yeah, if you could please fill out that poll, and we'll see if we can get a snap response and refer back to it as we go through the results. And I'm gonna just open the poll box to see how great. I'm very glad to see people responding so quickly. Great, this is great, and it seems as though, again, these results are, I think, consistent with a lot of what we've uncovered, and consistent with what I'd expect given what appear to be the ranges of experience, the ranges of experience in that you all have. And Clarence, I'm seeing the presentation has just disappeared. I'm hoping you may be able to re-add it. And while I'm waiting, while I'm waiting to do that, I'm going to just start to walk to the next slide before the visuals come up. So, but once we're able to get the slides back up on the screen for you all, the first slide that I'm going to be presenting to you is on the question of conversion rate, or what's sometimes known as a hit rate, a conversion rate which describes the number of villages that are declared as oh, thanks so much, Clarence, appreciate it. The number of villages that are declared ODF as a fraction of the number of villages that are triggered in a national program. Please excuse me while I navigate us to our slide. I'll be right there. Thanks everyone for their patience, and thanks to our great technical support for troubleshooting. Okay, so I started to describe this variable known as conversion rate. So if you were to trigger 100 villages and only 50 of them ended up self-declaring as open defecation free, you'd have a conversion rate of 50%. So these data are pulled from the Global Sanitation Fund's website. They've got a great website where they're quite transparent about their investments and the performance of their investments in different countries. And it's quite what I draw your attention here. What we're plotting is the conversion rate as a function. That's what you have on the y-axis. The number of villages declared ODF as a fraction of the total number of villages triggered, as a function of the scale of the program, which is the number of villages triggered, out of hypothesis that larger scale programs might have higher conversion rates insofar as they could develop all kinds of scale advantages. What I draw your attention to here is not really the bivariate distribution so much as just the range on the y-axis. You have conversion rates, reported conversion. And again, these are just for programs that are funded by the Global Sanitation Fund and managed by their partners. And that's distinctly a subset of the CLTS that's happening globally. But you see this range from on the order of 20% up to well above 85%. So there, there's quite the success at the national, reported success at the national scale can be quite variable. The next thing I'd like to talk about is slippage, also sometimes referred to as backsliding from open defecation free status. So these are data from two reviews, post-implementation evaluations. One that was done of the programs, of PLANS programs in Africa by Paul Tyndale Biscoe and collaborators. The other by Singh and Balfour in Kenya. And so here the first data point was the baseline, and in all of these cases the baseline occurs at ODF, at an ODF declaration, and the researchers then went back and surveyed a sample of villagers within villages that were previously declared ODF some period later. With the Tyndale Biscoe study goes as far back as 5 years, right? And effectively, the steeper the slope of those curves, the more backsliding or the more slippage there was from ODF status. And you see a range of numbers here, even within countries. You see Kenya backsliding as much as 50% over 3 years. In Sierra Leone, there was backsliding was judged to be a major problem. A little bit less so in Ethiopia, but there's inevitably some amount of backsliding, as we'd expect, some amount of slippage from ODF status. The question is how much, over what period of time, and then the follow-up question is what kinds of follow-up activities are required to ensure that slippage is minimized, and not only follow-up activities, but other complementary interventions, perhaps those that focus on the supply side so that more durable latrines are built and so forth. There are some very promising signs of sustainability that have been recently observed. I believe that Johnny Crocker, who is the lead author on the paper from which we pulled these figures, is an attendee of this webinar. So perhaps we'll have some discussion. Perhaps he'll be able to answer a question or two as we get into the Q&A and the discussion. But there's particularly within the Upper West region of Ghana and Oromia in Ethiopia, we see not only do we see these pretty dramatic declines in reported open defecation, but reductions that continue and are sustained over time. Obviously, there's performance varies by region and between countries. But it's important. The other reason I think we wanted to feature these data is that it's quite important to try to collect data over it as an extended time period as possible. I just will draw your attention to the data from Oromia and Ethiopia. I remember when reading Johnny and his team's first papers from Ethiopia. If you look at the 2014 numbers for Oromia, you would infer that health extension workers vastly outperform teachers as facilitators of CLTS triggerings after 1 year. But going back a year later, the teachers caught up, and the picture looks rather different there now. And so again, this is some of the data problem is being addressed in studies like these. Okay, does CLTS improve community health or specifically child health? And unfortunately, it's difficult for us to make really concrete determinations because there just aren't a lot of studies that have carefully measured the health impacts that are specific to community as opposed to household level interventions. The recent SHINE and WASH benefit studies, with which some of you may be familiar, were focused on household level interventions, not at community level interventions. So we would argue that they're less relevant for making a determination about CLTS. There are a few trials that examine the benefits of national level sanitation campaigns, such as those in India and in Tanzania, that employed CLTS as an element, as a component within certain localized contexts, but were really broader total sanitation campaigns. So they're less relevant, again, to our purposes. But to our knowledge, there are really only 2 peer-reviewed studies in which the sanitation intervention evaluated was distinctly CLTS. And the first was a study, again, we showed you some figures from it in Tamil Nadu back in 2009, a randomized trial, very carefully done randomized trial that did not detect impacts of the intervention on either diarrhea or child growth faltering. They detected some other benefits of the intervention having to do with toilet coverage, with reported safety. Perceived safety reported by women and girls. Those are important benefits, but with respect to health specifically, they did not detect impacts. More recently, many of you are probably aware of a study from Mali led by Amy Pickering and her collaborators that did not detect impacts on diarrhea, but did encouragingly detect improvements in linear growth and reductions in stunting prevalence from a program in Mali. It's important to recognize that the toilets that were built under that program were generally unimproved toilets, but they were still judged to be durable and well maintained. And that raises an important question about whether the installation of unimproved sanitation that might not meet the JMP criteria for improved, but that nonetheless meet basic hygienic criteria, may be sufficient to result in health improvements when they're adopted by large fractions of a community population. In effect, the question is unimproved sanitation that still meets a basic threshold good enough? And then the second thing is that there are some papers recently that have argued that there's evidence of herd protection against growth faltering or against disease that result from increasing community-wide coverage with sanitation. Two papers in particular, one from Mali that's again connected to the health study that's referenced above, and the second from Ecuador. Those are encouraging, and the community orientation of CLTS is consistent with these findings, and that's encouraging. Again, the Fuller study was not a CLTS study in Ecuador, but nonetheless, it provides another data point that there may be herd effects of sanitation. But I want to be quite circumspect about this, because those two papers were observational studies, and they're not controlled studies, and there may be more forthcoming about whether these herd effects really occur, or whether they may be just constrained to very rural, sparsely populated settings. So we have to be cautious. There are reasons for enthusiasm, but I think we need to be cautious still. So what do we, if we have anything like a summary slide of the results of our review, it's this one. It's the closest thing we have to a summary of the top line findings. Now, we're not showing any, for the researchers out there, we're not showing any forest plots. This wasn't a systematic review, but nonetheless. So open defecation, obviously not always measured, but some small reductions in open defecation were observed in controlled studies, ranging from 0 to 14 percentage points between a baseline prior to triggering and after. On latrine coverage, now this is a very important point. If you look at the reports that are controlled, that have a counterfactual, you tend to see a lower range of increases in toilet coverage than you do from studies that are, and reports that are uncontrolled, where someone is just reporting what occurred before and after triggering. And this dynamic is not unique to CLTS, but it does mean that we have to have some healthy skepticism of reports that that sound too good to be true. So if you hear after 3 months, open defecation was entirely eliminated in a district, it certainly makes sense to be cautious about how you interpret results like that. With respect to latrine quality, this is something that many of you implementers in the field have probably observed, that in cases where latrines are being built from local materials, again, clean and unimproved, fly-proof and unimproved may be good enough, but durability certainly is a problem that emerges repeatedly in the literature. Sustainability, we've shown some slides on sustainability based on slippage, both slippage and the sustainability of open defecation reductions resulting from CLTS programs. Equity, the evidence there is mixed. Michael Ganilo of UNICEF and Andy Robinson, who's a well-known evaluator and analyst of rural sanitation programs, in a chapter in a recent book put out by the CLTS Knowledge Hub, they caution that the poorest tend to be the first to backslide to open defecation, and they also say that the drive, the furious drive to quickly and completely end open defecation in a given community that occurs during a CLTS triggering can sometimes leave poor households with sanitation facilities that they don't like, or that they don't want, or aren't willing to use or maintain. Now, Amy Pickering and her team in Mali, they actually found pronounced benefits for the poor from the Mali program. They actually saw bigger gains in sanitation coverage among the poor than among the rest of the population. That's encouraging, but it's again a single data point. And some researchers looking at the program in East Java actually found the opposite. They found it in a randomized trial in East Java that the poorest income segments in the CLTS villages were no more likely to build toilets than those in the control villages. So yeah, I think the evidence there continues to be mixed. And health we've discussed in the last slide. I'm just going to skip that for now. I'm running a bit over time, but I should be done in about another 5 minutes. So I think we're right at about 30 minutes now. For those of you, again, who are implementers, and you're probably familiar with the CLTS handbook, and you may recall that the handbook does lay out these favorable versus unfavorable characteristics for CLTS success. And those operate at a number of levels. Those operate at the household level. Again, we've talked about wealth. Female-headed households tend to go open defecation free potentially at faster rates or higher rates than others. At the village level, we hear that small, remote, socially cohesive villages tend to be favorable. Those with strong leadership, those that have high baseline open defecation to begin with. A lot of that's reflected in some of Johnny Crocker's work. Adequate water supply, favorable environmental conditions. At the program level, the quality of facilitation, whether there is follow-up and how intense it may be, the capacity of an implementing institution, the employment of training and employment of natural leaders, or tradition. We now have some signs that traditional leaders can be really important in places like Zambia. And then, of course, the broader enabling environment, whether there were subsidies in a community in the past, that can make, if there were subsidies, there's this hypothesis that there's an expectation of subsidy, which can make a zero subsidy program like CLTS difficult. Of course, access to commercial supply chains for products and services. Again, if you trigger a community and households really want to build improved toilets, if they're not served by commercial supply chains, it's hard for them to act on that demand. And of course, the commitment of government officials is we hypothesize to be crucial. But I do want to say here that, and my colleague Carolyn will talk about this just at the end of this presentation. But this is an important list, but it doesn't necessarily tell us what the relative importance of different variables may be. Just my last two slides here. Clearly, who executes CLTS and how they do it can matter a great deal. A term we haven't used here yet is the term fidelity, implementation fidelity. Clearly, the organization overseeing a CLTS program in a given jurisdiction and the individuals conducting a triggering event, they appear to make a difference. Again, the same study I referenced from East Java earlier compared CLTS programs led by NGOs versus, or what were known in the study as resource agencies, versus local government institutions. And for some key variables, engagement with local counterparts, community participation, and visit frequency, the NGOs seemed to be better equipped to perform well in those areas, and consequently, the performance of CLTS in the RA-led areas was considerably higher than that led by local government institutions. And that raises clearly commitment of local government institutions is essential, but it does raise the question as to whether, in certain circumstances, how well local government institutions are equipped and how much capacity they have to actually lead in program implementation. That's going to vary from place to place. And of course, again, not referencing some more important work from Johnny Crocker and his colleagues. The training of natural leaders really resulted in a dramatic improvement in performance in one region of Ghana. In Ethiopia, there was some suggestion again that health extension workers were better equipped than teachers to execute these programs, but again, we saw that going back a year later sort of nullified those results. And if I'm mischaracterizing those results, I'll ask Johnny to set us straight during the Q&A. Lastly, there's a lot of attention that's been paid to the concept of social norms and changing social norms in the context of CLTS. And our desk review pays a little bit of attention to that topic. We're not going to really touch on it here, but the question of social cohesion is an interesting one. It's mentioned again. It's mentioned in the handbook, but it's not often measured. It can be hard to measure, and these same researchers in Indonesia, they opted to measure it, and they conducted a survey based on which was an index of participation, some surveying on networks, on trust and cohesion, and on crime and corruption, and they determined that villages with high amounts of social capital really saw higher reductions in OD than the others did. But also, and this is an important point, that in villages where there wasn't high social cohesion, CLTS could actually be damaging. At least, again, it's just one study from one particular locale, but something to keep an eye on. And then finally, so costs. This is the last one again. We're again citing, among others, Johnny Crocker's work, and together with others, as well as that of Bertha Persenio and Claire Chase from Tanzania. What you're seeing here are cost estimates, cost per household targeted in dollars on the y-axis, and on the x-axis you see different countries, estimates for different countries. And what I draw your attention to is a couple of things. Again, there's some variability, but if you look at sort of pure, that's probably not the right term, conventional CLTS, not pure CLTS, conventional CLTS, the cost range is broadly on the order of $10 to $30 per household targeted, and that goes across pretty wide geographies: East Africa, West Africa, in Asia. Again, you've got a disparity between these numbers from Nepal and from Bangladesh. I should mention that the other distinction here is between top-down costing and bottom-up costing. Those are two different methods for estimating costs that I'll wait till the Q&A to delve into. But there's a variability in cost. But the other key thing to keep in mind here is that the cost of CLTS, again, per household targeted, it's comparable with what Sanmark and performance-based subsidies to alleviate, to reduce cost constraints can cost on a per household basis. And it's easier for Sanmark and OBA programs, it's much easier to measure those costs per household reached, because it's much easier to account for a toilet installed or sold as opposed to the conversion from open defecation to ODF status at the household level. That's the end of my presentation. Just before we go to the Q&A, we're just going to offer a couple of slides that describe the next steps for the WASHPaLS CLTS research. And I'm going to invite Carolyn Dallaire from Akwaya in Nairobi to present these next couple of slides before we go to the Q&A. Take it away, Carolyn.
Thank you, Jeff. So really what this desk review has allowed us to assess is where are we right now with respect to knowledge on CLTS, and what does the sector need at this stage. And so from what we've read and from many consultations with implementers and other researchers, two research areas have emerged. So I'm just going to quickly present them to you so that you know where WASHPaLS research is going. So the first research area is really seeking to address the challenges of latrine quality, durability, and the issue of equity that CLTS sometimes faces. And the voice, again, that has emerged from the field is that to address these constraints, the affordability has to be increased. And so here the hypothesis that we're making is introducing smart subsidies, which are carefully timed with respect to triggering and carefully targeted at the poorest, can be able to improve CLTS outcomes in terms of latrine quality, durability, and especially for the poorest of the poor. Another thing that we'd like to investigate with this research is what are the best modalities for a smart subsidy. So timing is one, but how do we target, and what fraction of the population, and what should the subsidy amount be? So At this stage, we are looking for a country where it is timely to conduct such research, and for also an implementing partner willing to engage. And we envision this to be a quasi or experimental quantitative study with some qualitative research as needed. The second research area that has emerged is about what we coined the performance envelope of CLTS. So that is the set of conditions that make CLTS most successful. So you've seen this graph before, and this is a result of this. This is the combined knowledge that has emerged from the field as of today. But now what we don't know is how actionable is this, and in particular, what is the respective importance of each of these factors? One example is our structural characteristics, like the location and the size of the village, more or less important than the enabling environment or program implementation. So when we talk to practitioners, it seems that many people are of the opinion that when implemented correctly, CLTS can work everywhere. Now, this is what we would like to test. Is that true? And if so, what are those elements of program implementation that makes CLTS successful everywhere? So this research will actually be a mixed methods research project that will start with the analysis of existing program data. So we actually have put out a call globally for data on CLTS implementation. And following the statistical analysis, we will conduct case studies and qualitative research to better understand the findings that are emerging. So yeah, stay tuned. This research will unfold in the next couple of years. Thank you. Jeff, I'll hand it over back to you.
Great. Thanks so much, Carolyn. So yeah, just before I hand the mic back to Jesse and Morris, this presentation summarizes some top line findings of the desk review, which will be made public over the course of the next several weeks. It's undergoing some final revisions. We'll be very happy to share the review with you, obviously, and to hear your feedback as we're proceeding with our field research questions, and we're also continuing to look for partners for that research. And there'll also be, in addition to the review itself, which is a fairly dense document, some learning briefs, which will be perhaps a little more accessible at a quicker glance. So again, I just want to thank everyone for joining, and we're really looking forward to the discussion component. So, Jesse, take it away.
Yeah, thanks. So I'm going to try to get to everyone's questions. Some of them I'll group together. There are a number of similar questions. So the first question for you, Jeff, and the team, there was a number of questions on frequency of monitoring or intensity of the CLTS monitoring and follow-up, and how that may impact outcomes. What did you find in literature review? And if you could also comment on how that may impact cost.
Yeah, that's a fantastic question. And again, I'll invite Valentina and Carolyn to supplement my responses here. But and in particular, it would be useful to hear Valentina's perspectives from having talked to the key informants. But typically in many programs, the follow-up really is minimized as a component of the CLTS program. There's the pre-triggering stage and a triggering event, and if you see two follow-up visits or over a course of a couple of months, that can be unusual. In many places, there is this focus on the declaration of ODF status and the recognition of ODF, the public recognition of and certification of ODF status, and that's it. And I think there is a growing recognition even within the CLTS movement, as it were, that this is a weakness of many programs. The study in Amy Pickering's study of the program in Mali, and in Mali there was was a heavier touch program with continuing follow-up. Again, I'd like to make mention of the work that's happening in Zambia now. A firm called Acros has worked with the Zambian government to implement a mobile-to-web monitoring system in which toilet coverage at the village level is measured and reported on a monthly basis in perpetuity. Now there are some questions as to how sustainable this program, how long this will last, given again given a funding environment. Right now, these are programs that are funded by UNICEF, but there are also dramatic numbers being reported out of Zambia, which are, again, they're not controlled studies, but there certainly is. They certainly open up some hypotheses about how, whether for CLTS to really sustain its results, the touch needs to be ongoing. I don't know if Valentina or Carolyn wanted to add anything, or Jesse or Morris.
Doesn't sound like it. So, Caroline, go ahead.
Yeah, just to supplement, I will say that there is substantial evidence from several countries, at least Zambia, Indonesia, Zimbabwe, Bangladesh. Those are countries where there is quantitative evidence that the intensity of follow-up matters. And then there is the wealth of qualitative and more anecdotal evidence from many implementers. I feel that this is a consensus that more follow-up is needed. Yeah, and as Jeff mentioned, the Zambia case using chiefs as a key component as the follow-up process has been shown to also increase CLTS outcomes.
Great, thanks.
Jess, it's Valentina.
Yeah, go ahead.
I just wanted to add, maybe from the perspective of the people we interview, I think what Caroline said is precisely accurate. There is agreement that it's very important to do follow-up, but a lot of the people we interview said that it's not organized for at the beginning. We're not planning for it before we do the triggering or while we're doing the triggering, and often we don't know whether we should do it differently for communities where the triggering has resulted in a big reduction in open defecation versus in communities where we see very little moving, at least quickly, and so they wonder, should we do it differently in communities where ODF is not happening, or not even there is really not really even a reduction of open defecation that is, let's say, more than 30-40%. And finally, they say, when should we abandon the villages? So when we should not do follow-up at all? At what point should we decide to just abandon the villages? And that was also a concern. And then, the question is, in that case, what should we do then? We abandon them, and then what?
All right, sounds like we're Valentina's cutting out.
Sorry.
Yeah. Valentina, you're cutting out, so I think maybe we just move on to the next question here.
I think we probably missed the most compelling part of the answer. Sorry about that, folks.
Yeah. Well, sorry about that, Val. But so the next question is really about subsidies, and you already introduced the idea that we're very interested in subsidies versus CLTS, or with CLTS, by virtue of introducing our potential study. I wonder if you could elaborate that on a little bit. There was a mention in the comments, sort of reinforcing your description of the performance envelope, that maybe blanket subsidies could interfere with the CLTS process, but can you elaborate a little on the opportunities or research so far that we see around CLTS being integrated with subsidies, or target subsidies having success?
Caroline, do you want to get it started? And I can certainly add something if need be.
Yeah, of course. So thank you for the question, because it provides an opportunity to clarify. Of course, one of the main achievements of CLTS was to remove top-down blanket hardware subsidies, and everyone recognizes that, and there is no desire to go back in time. But now what we're talking about is a very targeted financial support to some select households who have no other way, who without it will not build durable latrines. And another aspect of it is that we're not going to be looking at full subsidies, but partial subsidies. And and it's indeed very important that they don't interfere with any of the CLTS community-driven process. And so it is perceived usually that if subsidies are introduced, they should be introduced later on in the process, when there's already been a lot of movement towards reducing open defecation. So there are examples actually across the world, mostly in Asia, I will say, of smart targeted subsidies being introduced at some point in the CLTS process, and usually it is after some sort of target has been reached, like let's say 80% of the households have a latrine, and now we focus on the remaining 20%. So when we say subsidy, we know we're bringing back the ghost of the policies that have not worked. So maybe let's not call them subsidies. Like it's really pro-poor support timed in a smart way. Yeah. So maybe Jeff, you want to comment additionally to that?
Yeah, I mean, we understand that this idea of subsidy, the potential, it's not uncontroversial, and that the zero subsidy orthodoxy of CLTS has been a central feature of the intervention for years. We have a sense that that's starting to change. The CLTS Knowledge Hub, together with UNICEF, convened a meeting in the spring that focuses on supporting the most vulnerable. And so I think that is changing. The other thing that's really important to remember is that there's now published evidence of how effective a partial subsidy can be to increase coverage. And this is really important, that there appear to be these positive spillover effects in which those households that are not eligible for subsidy also change their behavior, or also will elect to install a latrine by virtue of their neighbors who do receive a subsidy. And this is something of a counterintuitive result. Many of the folks involved in sanitation marketing efforts, worry about subsidy dampening demand for toilets on the commercial market. And there's the evidence there's one important, well-known paper now that was published in Science from Bangladesh, but there's some more research pending from Cambodia, in which sanitation marketing is integrated with a subsidy, and it was found to have, again, these same positive spillover effects, these same additive effects. And I also want to mention that a group called Eats Meets West, and based in Southeast Asia, together with the World Bank, and is in the process of a randomized trial that integrates CLTS with a subsidy program, and the end-line data are soon to be collected. So we should have some interesting results from there as well. Yeah, it's important to recognize that there does seem to be suggestive evidence that the most vulnerable can be left behind, and also that there are these sustainability problems that may be related to low quality latrines.
Great, thanks. And so that's a great segue, talking about things that can be combined with CLTS, to talk a little bit about, we have a number of other questions sort of referring back to what was actually coined by Darren Saywell from Plan as the performance envelope of CLTS. But could you elaborate a little bit more on the performance envelope? There were some specific questions to places like, is CLTS appropriate for pastoral areas? How important is, say, enabling environment versus a good facilitator? And comment a little bit on the idea of what we might call CLTS plus, which could include these targeted subsidies or hygiene programs or other activities layered or combined with CLTS. If you could comment a bit more on that, thanks.
Caroline, should we do the same thing again? Do you want to take the first crack?
Yeah, sure. Just right now, what we know is what has been published. Like this desk review tells us what has been shown or reported. So I have, for example, not read anything about the impacts or success of CLTS in pastoral communities. So yeah, I can't speak to that. What we're hoping, so just to give a bit more detail, is right now we have a wealth of information and knowledge about circumstances that have allowed CLTS to perform better, and they're all, we've listed them before. It seems that the problem is that not all of them are very actionable or do not allow to make decisions about where to roll out a program. And so what we're hoping to do is help prioritize, like use data to show evidence of how to prioritize these factors. And if there is data on that, obviously this will include additional activities that have been added to CLTS, whether it's Sunmark or additional follow-ups or the use of an ICT tool or providing guidance on latrines. So we do hope that we'll find the data set, the raw material for providing this knowledge.
I mean, what I would add here is you know, on the one hand, those who are familiar with the handbook would say, all right, well, we know where CLTS is likely to work and we know where it's not likely to work. And so we have what we need, which is, you know, I think there's some question about whether, what we don't know well is how important these different variables are in different settings. And so that's one of the objectives of this research would be to determine whether the data allows us to rank their importance in different kinds of settings, and to see whether, you know, we want to be careful. Implementers have been doing CLTS for long enough that their knowledge is really important, even if it's not published in a double-blinded RCT. Many of those of you who are attending, you know, can say, look, in my district, we just don't try CLTS in these areas for the following reasons. We've got our experience is powerful here. But you know, we feel like it is like it may well be worth the effort to try to compile whatever available performance data that we can to try to look for patterns, perhaps uncover patterns we might not have expected. You know, the data may not be rich enough to facilitate that, but we're in the formative stages of that work now. And some of you may have seen the data call that we issued last month, and we've gotten some encouraging response already. So that, yeah, we'll certainly be keeping everyone posted.
Just a little bit of a follow-up. Can you clarify, Carolyn? Can you clarify a bit more on the methods for investigating the performance envelope? Sure.
Thanks, Jesse. So we want to start from data that already exists, the monitoring data collected by implementing organizations worldwide. So here we're talking about Excel spreadsheets that people are compiling in their programs. And if we can collect enough of those or data sets that are representative of large territories, then we'll be conducting a statistical analysis of this data to see if there are any particular factors that are that seem to be very correlated with CLTS performance in terms of conversion rates or number of latrines built. So the parameters we're going to be testing for are distance, you know, how remote a village is, how small a community is, what was the open defecation rate before triggering, what was the number of, how many follow-ups, were there any additional activities added on to triggering, etc. So that's phase one. Phase two will be looking at what lessons are emerging from this data analysis, and then we'll go to the field and investigate further through case studies. So it's a mixed methods approach.
Great, thanks. Yeah, so hopefully that, I'm sorry, doesn't directly, many of your questions are asking us directly for advice on what to do in certain situations, and I think hopefully you understand we unfortunately can't give definitive answers on some of the questions because this, within the literature and the sector, we just don't know yet, but we hope to explore that through our research that Caroline just described. Next question, looking a little bit at health impacts. Jeff, you talked a little bit about some lack of health impacts showing up in certain studies and some health impacts in other studies. Can you talk a little bit about, at this point in time, do you have what is the policy relevance of some of those results?
I'm really glad that we got that question because, I think sometimes, particularly among the health researchers, we can kind of tie ourselves up into knots. I mean, there are important reasons to end open defecation and to deliver sanitation services to the rural poor that go beyond health. And I felt it was important to emphasize the perceptions of safety for women and girls as an example in southern India. So I guess, I think that what's important for us, sometimes there are claims made about what CLTS has accomplished with respect to health that we do need to be careful about not overselling or not speaking about not making claims that aren't verified. I guess what I'd suggest is ending open defecation and expanding sanitation coverage are just they're intrinsically valuable objectives to meet, and so I think that should be among most of many of the folks who are attending here. I think that should remain a focus, and it's our, I think it should be our hope that as we collect more data, as implementation professionation and experience builds, that we'll start to see more definitive examples of health benefits. I don't know if anyone else attending wants to. And by the way, we're soliciting questions, of course, from the attendees, but we're happy also to hear your opinions, or if you'd like to challenge anything that we're offering on these questions, please do.
Great, thanks, Jeff. Can you talk a little bit more about anything you find in the literature about CLTS and its maybe quantitative impact or on social norms? Or if you have any more information on CLTS impact on social norms, you could elaborate.
Yeah, I think that question came from Pavani Ram. Thank you so much for that. This social norms are a big have gotten a fair bit of attention in the sector of late, in particular UNICEF's focus on changing social norms. This is an area where, again, a lot that I think is still couched in theory as opposed to practice. You'll hear the closest that we were able to find in the literature about social norms changing, social norms changes driving success, were evidence of sanction by communities in response to open defecation. But again, we haven't talked in this presentation much, although we do address it a bit in the desk review. Some concerns about some concerns about shaming and in the human rights context, and shaming, causing really targeting vulnerable people. There's some ethical questions that have been raised about shaming, and even some questioning about it, whether the use of shaming is truly a participatory sort of community empowerment kind of measure. So my personal, I'm going to be careful here. My personal opinion about the social norms, about the arguments made about how critical it is to bring about a social norms change. We've not seen a whole lot that's been measured. The place I draw attention to is some of Dean Spear's work and the Rice Institute's work in India. I think that's quite compelling. This idea that the fraction of a community that reports practicing casteism, the practice of purity and untouchability, the fraction of a community that reports that bears more highly on a decision to build a household toilet. I'm sorry, to openly defecate than whether the household itself practices casteism. So there's a social. Again, none of this is experimental. These are data. These are census data that Dean Spears and his colleagues have analyzed. So I think that's in my mind the closest we have to something quantitative.
Great, thanks, Jeff. Next question is about, can you talk a little bit about anything you find about the regional differences in how CLTS is implemented? There was some particular questions about particular approaches in certain countries and different regions. So if anything you want to speak about regarding that.
Yeah, it's an interesting question. Yeah, Vale, how you spent time with the key informants. If we can get your mic to work or your connection works, do you want to take a crack at this one? Let's see if Vale is still on. She may not be. She may not be on. Yeah, I mean, there clearly there are places, for example, where there can be a backlash, for example, against the use of shaming, where it's sort of been heavily de-emphasized. That's the Valentina is trying to get through, but yeah, we're not hearing her on the system. So there are places where. Again, where shaming has been de-emphasized, in terms of sort of broad implementation differences in implementation modality. I don't know. I'm not ready to make sort of the broad assessments. I think the definition. One thing that varies widely, as we made reference to earlier, is the definition of ODF. And there, some countries have been much more aggressive about what counts as open defecation-free status. We've not spoken at all about the Philippines case, where there's really the Philippines has opted to employ a phased approach, where what comes first is a focus on ending open defecation, and then a focus on something like there are like stages of achievement, or like a total achievement of total sanitation coverage. There it's called the Philippines approach to total sanitation, FATS. Of course, we've seen multiple permutations of national sanitation programs in India. Of course, we've not spoken about India, but clearly, without speaking about India in terms of reducing the global burden of diarrheal disease, yeah, we're missing something. So, is Valentina?
Jeff?
Is Valentina on?
Yes, sorry to interrupt.
Yeah, please.
I've been trying. No, I think one of the differences we have seen regionally is that in some contexts, implementers give households during the triggering some sort of cheat sheets with Harvard options, so different types of latrines and different costs. So not really with the idea of prescribe, but with the idea that households can immediately get the latrine option they prefer. And these implementers suggest that households are unhappy to invest in a basic latrine and then see it collapsing. And so in order to kind of avoid these problems, they've started putting together these easy guides for households to use to decide which latrines to build. Another thing that has been changing regionally is that in some, or even within countries, in some cases, in some districts, for example, in Uganda, they're trying to build better latrines than what is required by the ODF definition. And this is because they have experienced that, building, again, the idea of building basic latrine is not enough for sustainability. And so they kind of require higher standards immediately. And this is not necessarily with cheat sheets, but simply, political commitment and facilitators promote higher quality latrines than what's recommended in the ODF or what's required by the ODF definitions. So these are two examples of these differences regionally.
Great, thanks so much for chiming in there. Yeah, I think it's totally clear that CLTS, as it is essentially a behavior change strategy, is highly contextual to every situation. So that could mean regionally, nationally, or even subnationally. And so we see those adaptions. We've talked about a number of them today, but as you look across the world and the different implementation, we see many adaptions at local level to how CLTS is implemented, and sometimes even by community. Certain communities react differently to the standard practices.
Just a quick, before we move to the next question, I would love to invite Valentina just to perhaps offer some observations about a particular implementation in Uganda, and your experiences interviewing our key informant, who is a district health official in Uganda, and an adaptation that he made locally, which I think would be useful for the group.
Yes, I mean the district official in Uganda that we interviewed was really adamant that the latrines needed to be the pit needed to be covered with cement, and that the roof needed to be of a particular type. And it was essentially making sure that everybody in that district had these higher standards of latrine. Now, he was also very clear that his district was not a district where poverty was a real problem, and because we discussed a lot whether an approach like that could be particularly problematic in areas where there were a lot of people that could not afford such standards. And so, this was a case. This was a district where a lot of the villages were not actually that poor, and even within villages, there seemed to be not a lot of problems for everybody to kind of adhere to these higher standards.
Great, thanks. There's a question about what did you see in your study for CLTS having an impact on other behaviors? For instance, say hand washing, or you mentioned before social cohesion, or other indicators. So is there any demonstrated impact on other outcomes from CLTS?
I'll invite the others to contribute here, but we were very much focused on open defecation and toilet coverage. We dedicated a little bit of attention to gender and social inclusion. But no, we certainly weren't focused on research that attempted to infer changes in other kinds of behavior outside of open defecation. Realizing that hand wash. I mean, there are a number of places where the presence of a hand washing station adjacent to or near to a latrine is a component of the ODF criterion, or a criterion of the ODF, the declaration of ODF. But anything else? Am I overlooking anything, Carolyn, Valentina? I don't think so.
I don't think so. I think it's...
All right, great. All right, so last sort of question is, how do we intend to disseminate these findings further and future findings of the research? Can you talk a little bit about that?
Certainly, yeah. So thanks for the question. We again, in addition to the physical documents that will be coming out of this research, the desk review itself, and some shorter learning briefs, we've got. We're also preparing some academic publications, and then certainly once the field research questions and designs are finalized, we're likely to be disseminating those. I think internally we'll be working through the dissemination modalities. But this is, I should mention, this is the first of the WASHPaLS webinars. There are likely to be a number of others that are going to follow in succession. Jesse mentioned the SANMARK, or the market-based sanitation desk review, as well as a literature review on play spaces and exposure of infants and young children to animal excreta and fecal contamination in the household. But there's certainly some possibility that we'll convene additional webinars while field data collection is ongoing. But yeah, it's a big part of the WASHPaLS project. And Jesse, I don't know if you want to weigh on this further. The partnerships aspect of WASHPaLS is a big one, and so it's something we'll be taking seriously.
All right, thanks, Jeff. Yes, in fact, so unfortunately we've come to the end of the time, and I'm sure there's lots of questions we didn't get to, but please feel free to reach out to myself, Jeff, or the WASHPaLS project director, Morris Israel, if you have further questions on this literature review. And yes, we do intend to distribute this through many forms and widely. One of those is it'll be posted, this recording of this webinar will be posted on globalwaters.org, our USAID website, as well as a sort of short summary of this research, and then the full paper will be coming out later in the month and will be distributed widely. But as Jeff mentions, this is primarily a learning project focused on learning with partners. And so we are seeking your input and your collaboration and your partnership. So part of the data call that Carolyn mentioned earlier, that's a first step in partnering on our particular research around performance envelope. And so please reach out if you have any questions on that or like to partner on that, or any other of the questions we mentioned today.
And Jesse, just one other thing, again, there are a number of individual questions we haven't addressed in this session. We had been talking earlier about what the possibilities may be to address them and disseminate other answers. And I guess we'll circle back internally to figure out the mechanics of how that might be done.
Yeah. In the meantime, if you have other questions or your critical question was answered, please reach out to us. So that's it for the webinar. Thank you everyone for participating. We're really happy to share this with the community and start to get your feedback and questions. And we hope this can be a useful resource going forward. And we're, as I said before, really seeking your partnership to then explore some of these sector gaps that we have prioritized in the sanitation sector. So with that, we'll end the webinar. Thank you all for attending. Take care, everyone.